Goodness, there is so much to teach you and so much to tell. We could literally spend days talking about surgery and HS, which makes it really hard. And many of you here have a very different understanding of what surgery is. Your perspective, the lens by which you look through surgery when you're sitting here is very different. So I'm going to try to break it down. And then hopefully later during the small group sessions, we can have some more conversation. So I'm a surgeon. I'm actually a trauma critical care surgeon. Um, I became interested in HS when I finished my residency training. I had an interest in complex wounds, which kind of comes with the trauma territory. And frankly, my senior partners started handing me these cases for surgery. Why? They weren't really interested in them. And as I started doing them and starting working with patients, I really was touched by them. And what I was seeing in patients was very different than what had been taught to me in a textbook, what had been taught to me during my residency training. And the procedures that we were taught did not really fit. So I somehow found this amazing world of dermatologists and the HS Foundation, and then over the years have become very active in it and have specialized in HS. So the perspective that I'm bringing today is it's not written anywhere in a book. It's years of experience, years of tweaking things, a lot of, I don't want to say quite trial and error, but the reality is that we're still learning and evolving in the field of hidradenitis. So every time we have a new advance in HS, even on the medical side, it impacts the surgical side as well. So I practice in Fredericksburg, Virginia, which is south of Washington, D.C., and north of Richmond, Virginia. Where is she? Oh, I was doing a shout out to Dia. But in any event, so I practice in Fredericksburg, Virginia, and I'm fortunate to, it's really a privilege and an honor to take care of people with HS and partner with you all through this. So a couple things. I am a board member of the HS Foundation. I'm also the chair of the upcoming meeting, which is the Symposium for Advances in Hidradenitis Suppurativa. It is in Austin, Texas, again. November 1st through 3rd. And we do have a number of patients who come and join us, patient advocacy groups. So you're more than welcome to join us. It's a very research heavy focused type of meeting. So it's very different than this type of meeting or some of the other patient-focused meetings, but it's typically very, very rewarding. I'm also the president and on the board of the HF's Coalition, which is a new, it will be a nonprofit very soon, advocacy group that has been funded through UCB. Thank you. And we are trying to change policy in the government so that we can get patients with HS better access to care, better coverage. So very excited about that. It's the one piece that was missing from all of the different work that we're doing as a field. So very excited. I also do some consulting work and so forth. And here's my disclaimer. I'm going to show some pictures. This stuff can be a shock to the system. I see this stuff every day. And I mean, I cut people's insides out all over. So for me, I sometimes forget how traumatic and disturbing this all can be. Feel free to walk out at any moment. I won't get offended. Feel free to say as a group, we got to stop. And I only have a few pictures. I've been very strategic about them. I am not including any female pubic pictures in there. I have a male pubic picture who he is totally happy for me to show everybody. But females, it's a little different. So, yeah, I'm sorry, I don't mean to discredit men in any way, but I don't want to just put somebody's labia or vaginal area, same thing out there. So I want to be respectful of that. I'm happy to show you one-on-one some things in a smaller form and so forth. So, all right, on that note, When we look at HS treatment in general, I think of it in terms of having three pillars. And this is what I explain to patients. There's medical treatment, there's surgical treatment, and then there's lifestyle modification. And all of these things together are really important and make up what all of the successful modalities that we need to help control HS long term. I'm going to digress about surgery for just a second, or talk about surgery for just a second. Years ago, when this disease was first described, it was actually thought to be like syphilis. Okay. So the thought was, and the way that they treated that form of syphilis was literally to cut it out. So this was first described in the 1850s, and someone said, well, that's it. We just cut it out. So the treatment for the surgical treatment for HS has always been to cut it out. And Dr. Dave Louis before spoke about the different Hurley stages, the stage 1, 2, and 3. And they were the initial way that surgeons decided who was appropriate for surgery and who was not appropriate for surgery. That's no longer the case. Okay. So I actually don't see a lot of value for me in the Hurley staging classification system, with the exception of if someone tells me or another physician tells me what type of stage it is, it gives me a little bit of a visual in the head. But everyone's HS is completely different. Everyone's HS looks different. Everyone's HS impacts them differently. Everyone's HS impacts them systemically differently. So it's very hard for someone to say, well, I had stage 2 and I had surgery and it worked great. Because for the other person who has stage 2, it may not work great. And we'll talk about why and all of those things shortly. But just keep in mind that you can't assume that everybody's HS, even in this room, looks exactly the same and impacts them exactly the same. So going back to surgery, the treatment has always been to cut it out. And the thought was, because it was underneath the arms, that it was a sweat gland disease, and we could, just cut it out and go on our way. The initial operations that were described for HS were only up in the armpit, and it's called a Pollock procedure. And literally, you draw a circle around it, you take it out, and you close it. So what happens? It's awful. Okay, people are stuck with their arms at the side. Many of you may have already had this, and when you look at the data's not good. Okay, for a couple of reasons. There's a pretty significant recurrence rate, and the reason being that this procedure is looking at it in terms of it being a focal limited disease, not a systemic disease, okay? We know that when you have HS in a specific area of the body, the normal looking skin around the HS lesion actually has transcriptomic or changes in the proteins, in the DNA even, okay, which leads to the proteins. So it's not normal skin. It may not be HS affected at that moment, but there's still changes. So what happens? Well, they either don't heal well, they fall apart. And again, there's a lot of different reasons for that as well. This isn't true in all of the cases, but in about 50%, it can be very challenging. The other thing is they often recur. And when they do recur, it's worse, because now what's happened is you've created this big line where the incision is. So like going across here, it recurs along the incision line. So sometimes you can make a bigger problem than what you had before. And we'll talk about some of these things as well. So what you read about your perspective of surgery, keep an open mind. What we know about surgery today is different. What most surgeons know about surgery for HS is not accurate. Okay, so just you and your followers and patients really have to be empowered to educate their surgeons so that you can ask the right questions, guide them in the right direction. Okay, so we talked about how everyone's HS is different. And as Dr. Dave Louis spoke about, it can really occur anywhere in the body. So it doesn't need to be limited to the anatomic regions that we traditionally think about. You may hear from physicians, you may go in and say, well, I have HS underneath my breast. And they say, oh, that's not HS. HS doesn't occur there. They're wrong, okay? They're wrong. So again, don't be discouraged. Educate them or find someone who's a good resource for you. All right. So what's happening below the skin? And as a surgeon too, I have the benefit of cutting into things that in and opening up the different lesions to see exactly what's going on. And there's a lot of different things that are happening underneath the skin. You can feel, but you can't see. Okay? And there's actually certain situations where the skin looks completely normal on top. And yet there's things going on underneath the skin which you can't see until you open it up. So it's not uncommon to have those hard inflammatory nodules that you all are unfortunately too aware of. Small pockets of fluid that are lined with a jelly. It's like a red inflammatory jelly. And honestly, this is the root of the problem. This is what causes your pain. This is what drives your inflammation. This what gets colonized with bacteria. Although, as Dr. Dave Louie mentioned, most of the times when you try to culture things, it doesn't grow out anything. I actually don't culture any of my patients for that matter. I think I don't even worry about MRSA. It's a bit of a myth to be worrying about those things. But you can get these small pockets that are lined with this jelly, tunnels that are lined with this jelly. Meanwhile, the body is trying to heal itself because your immune system's actually pretty strong, although it's not happy and it's attacking you. There's a part of it that's trying to heal things. So when we talk about these tunnels, in theory, and in some people, there may be just like one tunnel, but in reality, it's like the series of interconnecting tunnels with scar where your body is trying to heal. So they don't necessarily flow with one another. They're not necessarily contiguous with one another. And then we talked about the normal skin that can be above and around the area. So what's HS surgery? Anyone have any idea? Like, what does it mean when we say surgery for HS? And that's part of the problem. Everybody has a different perspective. So when someone says, I had surgery and it didn't work, and someone else says, I had surgery and it worked, you don't know what they had done. Or even someone who might say, well, I had 20 surgeries. The definition of surgery is very different for everybody. And that's actually one of the problems right now with the literature that we have, is that when we look at the studies in the research world, which have driven physicians' perspective of whether or not surgery works, it's like comparing apples to oranges. So there have only been a few more recent ones which have been remotely helpful. So when I think of surgery for HS, I'm going to break it down for you very easily. Okay, there's 3 different types. One is incision and drainage. Okay, so think about you have a cavity. And you're flaring and there's fluid inside and you're really, really uncomfortable. And you go into the ER or you go into the physician's office and what are they going to do? Anyone? They're going to drain it. Okay. So IND stands for incision and drainage. And what they're going to do is they're going to open it up and release the fluid. Sometimes it's kind of pussy, but it's not really pussy. It looks like pus, but it doesn't behave the same way an abscess or an infection behaves. The reason is it has that jelly-lined cavity, okay? So doctors think they drain it and it'll go away. So you get it drained, you go home, and what happens a couple weeks later? It's back up. Why? Because you still have all of that jelly, all of the material, all of the inflammatory process going on. So the purpose of IND can be effective depending on how you look at it. It's effective if you're in excruciating pain. Okay, not everybody needs it. HS Connect does not encourage it. I'm not a fan either. I think we don't encourage it for different reasons. For me, it burns bridges for my operative procedures later. Okay, because once you do that over and over again, you're prompting the body to make more scar. So I can't do more minimally invasive procedures in that area where I might be able to do it if I still had that cavity. Okay. HS Connect, I don't want to use your words, but the reality is there's a 99% recurrence rate. Why do we say 99? Because in 1% of people, they'll scar down so much that, in a small area, it may not come back. But for the most part, we don't view it as, I don't even view it as surgery. We don't view it as curative by any means. The purpose of it is purely for symptom relief if it's just too much and you can't do it. So in my practice, if someone really, really wants me to do it, I am happy to do it, but it's not something that I suggest doing on a regular basis. That being said, the last thing we want is for people with HS to suffer. So it's really a personal decision as to whether or not this is something that you want to have done or embark on, or something you choose to ride through or manage the pain, for example, manage the flare. And there are other medical modalities and things that we can do to help with that. Any questions about incision drainage? That's why I said this is going to take, I could talk for hours, so we'll get as far as we get, and then please.
So since it has like a 99% recurrence rate, do you think that it would be best for HS patients to avoid ERs?
So that is a loaded question, and I'm going to be very cautious with my answer. A lot of people with HS do not have access to any healthcare whatsoever. It is nearly impossible to get in with a dermatologist in a timely fashion. It is nearly impossible to find. I think I'm a little bit of a redheaded stepchild in the no offense to anyone with red hair in the room. Actually, I love it. I love it. I'm actually a slightly purple red or haired, although that's washing out too. But it's very hard to get access to care from both a dermatologist, from a surgeon, even a primary care doctor. Right now, a lot of people aren't taking primary care. The other piece is that a lot of patients don't have insurance, or they might have Medicaid, and a lot of places don't take Medicaid. So that means their only option is the ER. Okay. So if we tell people not to go to the ER, what we're doing is we're isolating them further from the medical community and limiting their ability to get care. And we don't want to do that. So the best thing we can do is, we as a field are trying to educate ED physicians. And frankly, it's similar. I mean, I won't lie, physicians are not interested in this disease. And that's a whole lunchtime conversation that we can have. And the I I think it's the more we can educate patients, the more patients can advocate for themselves when they go into the ER, or know how to manage this and know what to do. So it's going to take us time, but if someone needs to go to the ER, they should absolutely go to the ER, and discuss the different options, or use that as a way to arrange follow-up care, for example. Use HS Connect and some of the other patient advocacy groups to help provide information.
So there's a time when I went to an ER and they gave me prednisone, and then that helped cover like this time that I took the prednisone. Then after that, it made me go from stage 2 to like stage 3. So when we're going in those on the public's business, should we avoid steroids because we know you said it's bad?
No, not at all. Steroids are fantastic. So this is the confusing part with HS. Everything has its place, okay? And I completely and it does sound like in your case, after you took the steroids, you ended up at a stage 3. The problem is that we don't know if you would have ended up as a stage 3 if you didn't take the steroids. So for us to be able to say that the steroids specifically caused that from a medical standpoint is really tough. Okay. And for some people, steroids are life changing. And, when it is a little bit of trial and error, because everybody's HS is different. All the different signaling pathways in inflammation that are occurring in everyone's bodies right now are different. And that's why there's not one single medication that works really, really well. So they all have a role. And, when I look at the different medications that can be used in HS, I kind of think of them in a couple buckets. There's the antibiotics, which Dr. DeLuy spoke about, which we really use for more of their anti-inflammatory rather than their antimicrobial approach. But those have issues too. We're actually going to debate this at our upcoming SHSA meeting because we know that it also kills good bacteria, and we all have good bacteria in our gut. We need all that bacteria. So and we know that that bacteria is also linked to your immune system. So how does disrupting that impact your overall health? So they're not perfect either. Steroids, if you have a really bad inflammatory response, steroids are amazing. Chronic steroids are not good because that can have an issue. And then give me 1 second, I promise you. And then the other bucket of medications that I think about are going to be your hormonal therapies. Okay, so medical antibiotics, your steroids, your hormonal therapies, so your spironolactones, your birth control pills, things like that for people who have hormonal therapy. And then the fourth one, and I am generalizing, are the biologics. And those are the ones that have a greater impact on your immune system. Okay, so please. Oh, I'm sorry. I can keep going and you can interrupt me. Mhm. Yeah. So even though this isn't surgery, I love that we're having this conversation because the reality is these are the things that are going to make surgery successful, okay? And work. So the way to think about this and the way I explain this to my patients is it's a disease of the immune system. Your your body's attacking the hair follicles. You have inflammation everywhere, but it runs through your entire body. We're not even talking about the skin. This is a disease that runs through your body. So if I cut something out and you still got all that stuff running through your body, that's you're still going to have problems from the HS. And that's where those medications come in. So we can't and I don't know what your experience was in terms of other medications, but this is typically not a one drug, one modality type of disease. It's going to take all different kinds of things which can help reduce your inflammation in your body. And you've seen some of that already this morning with the art therapy, for example, or the counseling or the meditation. You're going to see that with the foods that you eat. And many of you know that already. Surgery can decrease the inflammatory burden. And then all these other medications can decrease your inflammatory burden. But there's not one pill that's going to work. So it's going to take a bunch of moving things around and figuring out that what works for you. I'll get to that. Yeah.
Like deciding what medication to use for what people. Because oftentimes, like I see a lot of people who are like, I tried spironolactone for several months, but it didn't work, or I tried this. But when I ask them, I'm like, okay, you're on spironolactone because they're high androgens, right? But oftentimes, like their hormones weren't like no one tested to see if they even had high androgens.
Well,
How are people choosing to which to try? Because instead of just being like seed and sticks, like is there a way to be a little more like systematic about it?
with hormones, we're not in a good place clinically and in medicine where we can really test and treat and track it that way. We typically use symptoms to help drive these kinds of things. So Dr. Dave Louie and I can look at people and say, we know your androgens are high because clinically we know the features. Yep, and just we can get that through a history, and just like the test for menopause, it's my husband will tell you it's not really a real thing most of the time because it goes all over the place. So same kind of situation here. You can't really test for the androgens in a clinically relevant way that will be helpful. But there's something else you said that I wanted to. It'll come to me. But there was an important point that you made. It'll come to me. Okay. Anyone else? All right. So incision and drainage. Let's move on. Oh, please. Nope, you're good. Hmm, hmm. Yep.
oil to it's got this
Yeah.
granula and that like this purring granula. Like how often is that occurring?
It we see PG, pyoderma granulosa, in the setting of HS. It's not as common. Um, People are afraid of PG, if that makes sense, because the mantra is that if you do more cutting and you provide more stress, it's just going to make it worse. There are certain, and it's typically treated systemically and with steroids and things like that by the dermatologist rather than the surgeons. I've actually had some luck in treating pyoderma in HS, similar to how I treat HS surgically, and had very good outcomes with it. So I don't know if that answers your question, but it's not as common. And basically, it's more examples of your immune system just going awry and your body trying to heal it, but can't really heal it. And you have too much inflammation. And it's this like push and pull battle that's going on internally in your body.
What's the difference between my surgeon was through plastic surgery?
Mm-hmm.
But I know that some people are recommending neurosurgery.
Yep. Hold that thought and I'll get to that. I promise. I hope I promise. We may have to go into lunch. Oh, how much time do we have?
We actually have 2 minutes left until, yeah, so, I was gonna say,
All right.
do we want to,
You want to go through it?
keep going, and then do we wanna just go into lunch a little bit?
We can also, if you, it depends what you all want. I'm here for you. But because I do realize that this is an important topic and a new topic, if you do want to just do a few more slides, go get lunch and bring it back. For those of you who want to stay, I'm happy to continue. Okay. All right. Give me a few more minutes to do for a good stopping point. Okay. So there's 3 types of procedures. We talked about incision and drainage. Second procedure is called deroofing. And this is a newer technique that's evolved. And the idea here is that if you think of a tunnel, and again, tunnels are not as simple as they sound, but let's think about this. Think about a house, okay? And you take the roof off the house and you look down into it and you clean out all the stuff that's in the house. So that's all that's left are the walls. And you've gotten the paint off the walls. You're down to like drywall. That's deroofing, okay? So with a tunnel, you're opening up the tunnel, you're cutting out the skin on top of the tunnel so that the tunnel's like splayed open like this, and then you're getting rid of all that red jelly that's inside, okay? And that red jelly is the essence of HS that's keeping your body from healing in that spot. So I love that. So once you remove the jelly, or as Brindley knows, I affectionately sometimes call it the gelatinous crap, because there is no better term for it. I hope that's not offensive to anyone in any way. They heal up beautifully. Now, if you didn't have it running through your body, and if you just had one small area, that would be really easy. But a lot of people have multiple interconnecting tunnels with scar and things like that. So it's not quite that simple. But here's a picture of a deroofing. The way it's described is a probe is put in. I do it slightly differently, an iteration of this. But the idea is we can open up the tunnel. This is the jelly, okay? This is the jelly here, and then we scrape it out and look how it heals up. Now, both, okay? And that's another, so a small area we can do in the office awake if that's something that you're comfortable with. Some of my patients say, you know what, it's too traumatic. I can't do this, okay? For the more complex stuff, I do it in the operating room. And I do instead of this area, I might have this area and do a complex deroofing on that whole area, which can take hours to go through and chase all the tunnels and find all of them to get every bit of the disease out. The nice thing about deroofing is that you're not going down into your fatty tissue layer, okay? So when you think of people being concerned about cosmetic disfigurement after surgery, you're not taking away your chunk in a good way. The things that give you the contour in your body. So like if I were to cut out a chunk of butt, I've taken out your sorry, I'm touching my butt. Yeah, I'm taking out your fatty tissue too. I've turned my butt into a flat butt. Here, I'm staying above all that fatty tissue and leaving it there so you still have your chunk. Same thing we talked about. Actually, that's a good time to go into the excision. Oops. So let's talk about excision. Excision, you draw a picture around it, and there's lots of different opinions as far as how much you take or how much you don't take. I'll have my perspective, frankly, is we call certain things wide local excision, and this comes from the cancer literature, where we have studies that say, well, in a melanoma or in a skin cancer, you need a certain distance around it to decrease recurrence rates. And that's what a wide local excision refers to. Well, the reality is this isn't a cancer. This is also a systemic disease. So we know that when we're removing this, we're not removing all the disease in your entire body, and we're not removing the processes that are causing this disease to happen. So I just remove everything I can see and feel with my hands, my naked eye when I'm going through. I did mention that sometimes, like this patient up here, I mean, I can tell by looking at it, but the disease, even though the skin looks normal here, goes up till about there. This is an armpit. All my pictures I try to take where you can't tell who anyone is, nobody can identify it, and so forth. So when I do this, I draw a circle around it, basically, and then cut down to the fat. And this is fatty tissue. That's it. Okay? It's just that yellow kind of bumpy-ish tissue. So
Take my agents away.
okay.
Well, you live close enough.
That is true. I mean, we could do it here if you wanted, right? So that we'll do in the operating room. So 3 procedures. Surgery is 3 procedures. Incision, and actually, like I said, I don't consider incision and drainage a surgery. So if someone says to you, I have 20 surgeries, they didn't work, it's likely that it was mostly incision and drainage. Not the case always. Again, we'll talk about this a little more. De-roofings, and then excision. Those are the only things that exist right now. How we heal them, whole nother story, okay? And there's a lot of different options, and I have very strong opinions on that as well. And to your point before about which doctors do this, which surgeons do this, each of them will have a preference based on how they were trained and what their knowledge of HS is, which could be good or bad for you. But we'll try to cover that as well. So any questions about those 3 techniques? Okay. Who's first? I think it was like a race to see who's first. Yeah, anyone, go for it.
So I had surgery a year ago,
Mm-hmm.
and it was the type they typically put you under for because it was extensive,
Mm-hmm.
like multiple areas. But I had to fly home the same day, so I
Mhm.
waited for it.
Mhm.
Very interesting to watch. But for me, I found it really interesting because for 3 months after the surgery, the spots were never worse. Like the surgical sites became injected in, but then they went away and it never grew better. But I never got
Okay. So it wasn't HS. Okay. And this is really confusing. I'm going to advance the jelly material. Hold on. I told you we got more fun to be had. I'm sorry. All right, just look here for a second. See this? This is not HS jelly. This is called granulation tissue. This is good bloody tissue that your body's depositing to help it heal. Now, if you had a lot of pain, what could have happened was a couple things. Number one is you could have had disease around the edges that was the stress of the surgery actually triggered it to flare. Okay, so that was one possibility. Number two is or they didn't get it all out but again, the goal isn't to get it all out; it's to get the root of it out, so to speak. The other thing is that after surgery, When you do surgery, you're traumatizing the skin. Okay. So your body's going to respond in the same way. It's going to create inflammation. The edges are going to get red. Sometimes you can get some slough or gunk that kind of fills up around the edges, which actually causes pain. People don't believe me, but once the gunk is gone, it doesn't hurt anymore. So it's very possible. And what I think probably happened is you were going through the normal stages of wound healing, just not knowing that was part of the normal staging of wound healing.
I want to know why.
It's granulation tissue.